Please welcome former CEO of Apple and PepsiCo, John Sculley, and interviewer Mark Hodash, co-host and founder Life Itself, to discuss disrupting healthcare through technology and innovation.
Hi, I'm Mark Hodash from the Life Itself, and I'm really thrilled and excited to be here today with the one and only John Sculley. John is the former CEO of PepsiCo and also the former CEO of Apple, and has so much to tell us today about the world of healthcare, particularly from the perspective of technology and design. So John, thanks for being here.
Thank you, Mark.
John, I wanted to ask you, you had the privilege of being able to work with certainly the most well-known, I would say, technology developer, Steve Jobs, and or marketer, however you kind of look at Steve, and you learned so much from him. I'm wondering what you learned from Steve in regards to computers in the early days that would apply to healthcare. What lessons do you think that you kind of learned from him that we should be thinking about?
Well, I did work with Steve Jobs and Bill Gates back at the early days of the information economy. And it's exciting to be able to be working in the early days of the digital health economy. So what I learned from Steve was that you have to have a set of first principles. You want to have a purpose-driven organization, and you want to have a really big idea in terms of how you can not only change the world, but how you can motivate really talented people to want to come and do it with you. Because Steve knew that the greatest skill he had was not building products. He was not an engineer, but he was able to recruit just extraordinarily talented individuals who worked together as a team. And it was Steve's ability to recruit them and to motivate them that I think set such high standards for Apple that we all enjoy today.
He was focused on design and the user experience. And I would argue that even at PepsiCo, you came from a world where it was largely about emotion. Drink this and you'll feel great. Could healthcare use a little bit of that to change the way people's behaviors are, change this behavior and you'll feel great? Because it's so hard to change behaviors, but companies like Pepsi and Apple do that.
Well, you're absolutely right. Behavior change is what the next era of healthcare is going to be all about. You can only do that if you start with the consumer, the patient, the person who is going to be most impacted if they do change their behavior. And up until now, the healthcare industry has largely been a sick care industry. 85% of the spend in healthcare in the United States is for people who are chronically ill. So if we can begin to pivot towards preventative care, if we can begin to get people to focus on what can they do for better proactive health, which is all about taking responsibility for their own behavior.
I'm wondering, I think you're involved in a company that works with AI, artificial intelligence, machine learning. How do you see that role or that technology really impacting healthcare? What areas do you think it's going to be most applicable?
Well, I'm actually involved with several companies that are using machine learning and AI because they're becoming such foundational technologies for basically everything that is transformative in the world today. But let me give you a couple of examples. A company in the UK, which is called Zedson, we are using 3D medical grade sensors to be able to do things non-invasively that you couldn't imagine was possible even a few years ago. For example, we can look through the epidermis, the skin, and we can non-invasively not only measure accurately one's blood glucose levels, particularly important for diabetics, but we can also look at other blood constituents like electrolytes, like hemoglobin, being able to identify many things about the life source of who we are as human beings, which is our blood, and being able to give people signals that we can then analyze with artificial intelligence and interpret them longitudinally over time. And this opens up a whole new horizon for being able to give people better information for their own better behavior changes that they can make.
How about in drug development? Do you see AI playing a big role in developing drugs, and particularly from a personalized perspective? Are you involved in anything in that regard? Is that?
Well, I am involved in life science with a company called Cellularity, where we are doing placenta blood cord stem cells. This had nothing to do with designer babies. This is purely about taking placenta stem cells and being able to do things like developing cancer cures, or being able to look at functional changes with regenerative medicine. So that, for example, we're actually able to start to look at developing things that can extend people's life, higher quality of life, all with the ability to use stem cells. But the high-tech technology, I think, to go back to your question about artificial intelligence, one of the big areas that I'm involved with is called healthcare automation. And by that, I mean that if you look at the roughly $4 trillion we spend in the US on health spend every year, about a quarter of that, almost $1 trillion, is in things that are avoidable, misuse, all kinds of inefficiencies in the healthcare system that you can bring in what is called robotic process automation, meaning little smart robots, all software embedded with algorithms for machine learning or artificial intelligence, that are able to go in and at dramatically lower costs and far greater accuracy are able to take on all kinds of tasks, particularly tasks that are dealing with the complexity of rules and regulations in healthcare, and be able to do that far more accurately than humans could do it. So machine learning and artificial intelligence can have huge impact, not only in the processes and systems and delivery of healthcare, but it can also have big impact in terms of giving consumers better information to be able to manage their own proactive wellness.
Is Apple a future major healthcare company?
Well, Tim Cook said that he believes that one of the great legacies of Apple, if you look back decades from now, will be its contribution to health. And I think there's good reason for that to make sense, because Apple's been very clear. It does not want to be in the business of actually taking the place of the doctor or taking the place of the hospital system. What they want to do is to be able to use their understanding of technology, like an Apple Watch or any other wearable for that matter, where you can actually measure with sensors different attributes. It could be sleep, it could be blood glucose, it could be measuring your heart rates or your heart health. All of these things are going to get better and better with technology. What Apple has said they want to do is they want to be able to take these wearable devices with smart sensors and be able to deliver that. They now have about 150 million first-tier profile organizations, and they provide them with that data and then let them do the actual care of patients. Apple doesn't want to be doing that part of the process themselves.
John, last question. I'm wondering what got you into healthcare, from coming from Pepsi and Apple. What took you into the field of healthcare? Where does your interest lie to be so involved and invested in this field?
Mark, I can remember about 15 years ago, one of my great friends, Bob Metcalfe, who invented Ethernet, which we know is the foundational technology for the internet, said, John, people like you and me, as we get older, we need to reinvent ourselves. And I thought back to the early days that I was working with Bill Gates and Steve Jobs, and how they used to talk about how they were going to change the world. Bill was going to do it with software. Steve was going to do it with beautiful design and user experience. And both of them said that they were going to make it a noble cause. They were going to do something that would have longevity, well beyond their own time. And that stuck with me through the decades. And so when Bob Metcalfe said, why don't you reinvent yourself? I said, I'm going to pick something that I think can be interpreted as a noble cause. And so I picked healthcare, and I've been at it for the last 15 years. And I'm just thrilled that I chose that path to go.
Well, I remember when you and Bob Metcalfe and others, I think were judges at the first robotics competition that I helped lead years ago. And you're all an inspiration to the future generations to help start these great companies and technologies. And so I thank you for that. I thank you for being here with us today. Thanks, John.
Thank you, Mark.
To discuss medicine outside the hospital, we have with us Jonathan Bush, Executive Chairman of Firefly Health, Joseph DeVivo, President, Hospital and Health Systems of Teladoc Health, and Dr. Stephen Klasko, president of Thomas Jefferson University and CEO of Jefferson Health.
Hello, I'm Dr. Stephen Klasko, and I'm thrilled to be here at the International Vatican Conference talking to two folks that are really transforming healthcare. You know, one of the things that has really hit me is that for the first time, we are now talking about healthcare as a consumer experience. I like to use a quote that Jason Kidd used when he went as the point guard for the Dallas Mavericks, and they were 24 and 52. And he said, I'm going to turn this team around 360 degrees. We do a lot of turning things around 360 degrees in healthcare, and I'm thrilled to be with two people that are really looking at a very different future. So let me start with you, Joe. Through InTouch and Teladoc, you've been a pioneer in telehealth. But I think you would agree that telehealth is sort of an old term. We don't wake up in the morning and say, hey, I think I'm going to telebank. It's just that banking went from being incredibly inconvenient, mostly at a bank, to really convenient, mostly at home. And as I understand with Teladoc and Livongo and InTouch, that's really the future that you see in connected care. I'd love to hear about that.
Well, thank you, Dr. Klasko. It's a pleasure to be joining you. In virtual care, you're absolutely right. We've been focusing for years on use cases that would allow physicians to provide care remotely, to allow patients in need to get the type of urgent care that they desire. But what we aspire to do is to be a part of a patient journey and be a part of that digital journey through the health system where we can intervene in a manner that allows convenience, that allows urgency, and that allows efficiency. And just as the analog you make in banking, we don't see the interaction, whether it's live or virtual, as a different experience. We just see today our self-banking. And I think our desire is to get to that penetration. And in healthcare, it's about access. In virtual care, it's about cost reduction. It's about leveraging current capabilities across geographies that allow for care to be delivered and to be a great democratization of healthcare. At Teladoc, we have assembled an incredible amount of assets around that patient journey, whether it's inpatient care and bringing specialists in facilities around the world, whether it's on-demand care, or whether it's virtual care that can help chronic care patients and the highest cost and the patients in most need. It's an exciting journey, and we hope to accomplish the goal, as you had mentioned, Dr. Klasko, that virtual care just becomes healthcare.
Yeah, thanks. And so, Jonathan, so Joe is really fighting the good fight of getting care from hospital-driven to healthcare at home. You're looking to create healthcare that's half price but twice as good. So, two questions. One is, first of all, Firefly. As I understand it, according to Wikipedia, that's a beetle in the glowworm family. So why Firefly Health? And secondly, it seems like most of our health policy, especially in our country, the United States, has been how do we give more people access to this broken, fragmented, expensive, and inequitable system? What are you doing to change all that?
Well, I think, well, thanks for having me. It's good company here with Joe, who's made such a huge success of Teladoc. We're just water skiing behind the wake that Teladoc has established with more of a mile deep, less wide offering. So Firefly Health, which is named for I have no idea what, but the founders get to name their company. Two great doctors who had the courage to leave the sinecure of academic medicine at Harvard Medical School and go off into the desert. When you do that, you get written about, or at least you get to name your chapter. And so these guys have called it Firefly. And essentially what they've done is said, hey, what we've learned from Teladoc is that people really, and with a little help from COVID, people really are comfortable getting quite a lot of care virtually. But right now, they don't experience any benefit in the enormous cost savings that comes from that. Insurance premiums continue to march upward, and there is no correlation between your willingness to use virtual care and your premium, what you pay as an employer or as an employee. So what Firefly has done is said, hey, let's go further. Let's find the people that are really interested in saving money, offer them a better product because you just have so much more access to your doctor, 12-minute response time, 18 hours a day, and pretty decent response time in the middle of the night, to a care team that is dedicated to you and knows you, works, has done a full 360 on your health history, is constantly updating it with all manner of updates, from your grocery spend to your exercise to your sleep to, of course, clinical readings where necessary, blood tests, and etc. Let those guys actually procure for you the rest of care in a way that skirts the growing kind of islands of vertical monopoly around health corps, except for hospital systems, except for yours, of course, Dr. Klasko. And by doing that, by pulling the person out from the local health system and saying, we'll be glad to use you for things that are a good rate, we can actually not just deliver the virtual care more cheaply, but purchase procedures more cheaply and better. Not just more cheaply, but better. If we can route all of the hip, we've read about this. There's been business cases about this. We read about Arvind Eye and all these wonderful places in India, where there is a demand curve working, and so you have these incredible outcomes and incredibly low overhead per procedure. So Firefly is going to engage in that as well. Try to create demand for folks that are willing to bundle and package and price aggressively around procedures. So scoop them up out of the terrestrial world, get them to agree to go virtual first wherever possible, and agree to go virtually and in person where Firefly sends you. And all of a sudden, you've got a ton of money left over. And rather than keep it, because we're small and insecure and want market share, we're passing it forward.
And I think that is a good lesson for the legacy health systems and legacy insurers. We do fall victim to a little bit of it's hard to get somebody to do something when their salary depends upon them not doing it, which I think is what happens to many of us in hospital systems. But so, all right, so the easy questions are now over. And I'm going to go back to you for a minute, Joe. So, I had the opportunity to give a talk with Hemant in Asia, who's been my partner. We wrote a book together called On Healthcare. And, one of the questions that got asked to us, which I thought was a good question, is how do we make sure that these amazing advances in Silicon Valley, whether it's Teladoc or Livongo or any of these things that we're seeing, aren't just making the wealthy healthier? How do we start to really make sure that we're using these amazing advances to start to address the social determinants of health?
It's a great question. And one of the things we've always hoped that would happen was that virtual care would start breaking those paradigms of everyone having to go to the shrine. And a lot of the major health systems are not geographically inclined to meet need where the patients are at. What we want to do is bring the excellence inside the health system to be anywhere in the world. And you do that by bending the cost curve, having secure technology. And of course, there's a social determinant to the extent that internet access is there. And you can't just have $1,000 iPad be your portal and everyone having to get that. So there are a lot of things that we control, a lot of things that we don't control. But what we've focused on is allowing the technology to transmute a physician safely and securely to any location in the world. We have data centers that are centrifugally placed around the world that allows for a physician to be able to provide consultations in all third world countries. And actually, inside of Teladoc, we've started our own 501c called the World Telehealth Initiative. And what we do with the World Telehealth Initiative is we donate our products and services that allow clinics around the world who might be in need of an OBGYN, might be in need of a nephrologist or a hematologist. And then we help matchmake with physicians who are willing to donate their time. And then through our technology, bring them into a clinic in Malawi, bring them into a clinic in Rajapur, in all types of places that people would be able to provide care, because virtual care is the great equalizer. It is the great can be the great democratization. And it's like the house call. Back in the 1800s, we didn't have the institutions people would travel to. We had doctors who would travel and be amongst the community. And virtual care is a way to get that type of personalized medicine efficiently without borders anywhere in the world.
Yeah, I love the fact that you brought up connectivity, because I think that I had written an article about connectivity being the new vital sign.
Mhm.
In Philadelphia, literally the number one cause of people being hospitalized or dying from COVID was not whether they wore a mask or whether they socially distanced or the genomic code. It was literally their zip code, and the zip codes that had the least amount of connectivity, because they weren't able to take advantage of telehealth or online education, were really the ones that suffered the most. So I love to hear that. So Jonathan, let me you come from a very political family. We have a new administration, and so we're sitting here, and we're all agreeing that healthcare has to change. So if President Biden had asked you to become the head of the Department of Health and Human Services rather than Gabriela Becerra, what are some of the first things that you would do to try to transform the system so it could take advantage of some of the things that both of you have been talking about?
I think the first thing I would do is a lot of deep breathing to get oxygen back in so that I could stand up after collapsing at the thought that he would do that. But I think we learned a lot from Machiavelli and, even the New Testament with regards to edge computing and change. You don't attack the castle and say, everyone must do this. You say, hey, wherever 2 or 3 are gathered in this name, we can start there and do work. What Teladoc did, and which we are all copying, is start with low-hanging, easy fruit out at the fringe and make it super easy and frankly super affordable. At scale. Teladoc's pricing depends on how much you use it, but to start the game of living under the new truth. Social determinants, as you mentioned in your Philly example, drive 80% of our spend. These are things that need not one great cure where you take your knickers off, fill out a clipboard, and sit on wax paper, and someone in a white coat, fixes it. That's a lovely thought, and every once in a while that does happen, and we do an amazing job at it. Here in Boston, we had the marathon bombing, and those geniuses in those white coats just raged against the light, dying of the light, and won every single time. It was incredible, and it made everyone weep. But 90 or 80% of what we're doing is not that. It's regular low-level touching relating to eating and sleeping and smoking and drinking and just all kinds of chronic things. And this ability to get out in the edge, in the village, in the field, and start with that new doctrine is massively consequential to the downstream cost. Never mind the things you can do when you get people not locked into one place that may have a monopoly and be overcharging. I think that social element of getting people to realize how much care they can get, how cheaply, is something that the government should absolutely, resonate with. We had a big, we're enamored of our Manhattan projects and our Normandy stormings and we're going to all force it through, top down. We're going to get there. We're tired of this waiting kind of thing. But the truth is, the way these things work are all great changes, other than caused by war or pandemic, frankly. In this case, pandemic has actually helped us. They're outside-in phenomena, and what the government should do is focus on the things that block that. Teladoc was very brave early days. All these state medical associations desperately tried to block Teladoc. It's still, you have to have a license in all 50 states. Each doctor has to go and get 50 separate licenses to do a national. It's hilarious. It's somewhere. It's Monty Python meets Joe Stalin. Like, is it sickening or is it sad? There's all kinds of things that with no cost could be lightened up to allow the virtualization, the edge computing of medicine to begin and pick up more aggressively. I think it's bipartisan. I don't think anybody benefits from you not being able to talk to an OBGYN patient in Nebraska who desperately needs one right now.
Yeah, look, I love that. I did get a call from the Biden-Harris team for my suggestions, and I pretty much said the same thing. I said, what we sort of need is a bipartisan 9/11 commission for healthcare. You know, if you think about it, when 9/11 happened, the Democrats blamed the Republicans blamed the Democrats. But at some point, they got up and said, we failed to keep the country safe. Let's own it, and let's get some really smart people, you know, under the radar for 6 months and figure out what we can do. I think it's time for us to say we have failed to literally make healthcare accessible to all, and recognize again that our health policy has just been sort of a little bit cowardly in just saying, well, we'll just figure out ways to put out more and more money, but not really address the insurance issues, the equity issues, the how we pay doctors issues, the end of life issues, et cetera. So Joe, let me follow up with what Jonathan said, because I'll give you a real live example. You know, I'm an obstetrician. I can physically practice in 49 states if I choose to practice there, but I can only do telehealth in about 16. And getting back to your banking example is, you know, if I needed a different ATM for every state that I went to with a different code, my guess is that the banking wouldn't have gotten virtual. So, you know, this seems like a no-brainer. I mean, you know, like given what happened with the pandemic and how important telehealth was, what do we need to do to get rid of roadblocks, either private roadblocks or public roadblocks or consumer roadblocks?
Well, how about a crisis with a significant catalyzing event that forces everyone to change their institutional thought process? I think it's Winston Churchill who said, you don't waste a good crisis. And the learning curve that our society has now gone through with this horrible pandemic has been a catalyzing event. We've seen today that, you know, the release of or a temporary release of licensure. And at the end of the day, we're going to see reimbursement policy change. We're going to see licensure policy change to where it should be. Because we have to continue to protect the patient. We have to make sure that everything is done properly. And that's why virtual care has been so important versus conference call. You know, we're doing a conference call right now, but there are many different ways to ensure within medicine that this is a safe and secure, and that you know you're talking to a doctor, or you know you're talking to the right patient, or you know that, you know, there has to be controls in a sense, because we are still treating patients. And so there is a fine balance between opening up policy, but also making sure that we know that we are doing medical procedures, that we are, especially in situations where people are consulting, and it's a very time-sensitive, life-altering event where the decision that remote physician makes is not just whether or not you need a antibiotic because you're not feeling well, but whether or not you need TPA for a stroke, and whether you know that. And so we do have to have a fine balance. It does need to be paid. We have to make sure that there are the right motivations for that payment, and we also have to make sure that there are checks and balances, that the right doctors are getting to the right patients to deliver the right care.
So look, I'm saving the toughest question for last, and you each get 30 seconds to answer it, okay? So, you know, and this is this: if we had known in the Industrial Revolution that the internal combustion engine might cause climate change, we might have made some changes. If we had known that that in the social media revolution, that Facebook and Twitter weren't just so that I could see my cute grandkids on Facebook, but could affect elections and spew hate, we might have put some guardrails in. I wrote an article called "Trust is More Important Than Technology." And people have lost trust in technology. I think that's a big part of vaccine hesitancy, you know, why Google wasn't able to do contact tracing. How do we put trust back into technology? 30 seconds, Joe.
Well, it is a very good question. And it actually goes to some of the areas that I really just mentioned. In medicine, you know, there's so much big tech feels that because there is a large scalable solution, that it's transferable into healthcare. Healthcare, we have people's lives on the lines. We have their data security on the line. We have the ability to ensure that, you know, we're managing them correctly and that we're available to them. And so I think where technology meets medicine, where healthcare meets IT, we always have to make sure that we have a medical grade technology that ensures that safety and security. And we can't compromise. We can't compromise efficiency for that type of reliability.
Jonathan, you've always been about trust. 20 seconds.
I agree, but I don't agree that we would have not done the combustion engine or all those other things. I believe we have to go through an evolutionary journey. You know, we wouldn't have the electric car. We didn't have a super, you know.
So it's really just a matter of time.
We are evolving.
Got
We're learning. Social media is, you know, it's a little bit like Christianity in this country. People give all kinds of valid critique of Christianity, but those are frailties after thousands of years of providing hope and life. The entire universal ethics notion may come from there. So in my idea with medicine, you know, we have just like we've seen this in these three spaces you see on the screen, right? You've created the most conscientious, incredible learning center in the traditional sort of temple-based, structure-based model. Teladoc comes along and scrapes a bunch of activity out away, just almost like an Uber, grab some advice. And now you see companies like Firefly saying, hey, let's colonize out here. Let's live in Boomland. Let's build whole products. I think that's the way things should evolve. I think when we get scared of change and block it, say block social media because we don't like a thing they did, or block religion, or block telemedicine, that's when that fear of what may come next and that it may be bad is what we need to manage most of all.
So look, I love that learning experience thing, and we're out of time. And this has been an incredible conversation, and I really appreciate both being part of this, but also what you're doing to help transform healthcare. So thank you both.
The symposium around building a more equitable health system for all will be moderated by Dr. David Nash, founding Dean Emeritus of Jefferson College of Population Health.
Well, it's so great to be here for the first virtual, but the 5th annual International Vatican Conference. And I'm here with some outstanding friends from all around the world. What a great opportunity. My only wish is that we could all be physically together, but next time we'll be in Rome together. So I'm here today with Dr. Paul Farmer of Partners in Health, Dr. Walter Ricciardi of the World Federation of Public Health Associations, and Dr. Chelsea Clinton of the Clinton Foundation. Welcome, colleagues. Great to have you with me. Our topic today couldn't be more timely, right? Building a more equitable health system for all. My goodness, what the world has been through in the past year and a half almost, and what's happening right now in different parts of the globe. I couldn't think of a better team to put together for this amazing meeting to tackle how do we build a more equitable healthcare system. So let me start with Paul Farmer. Paul, you have been all over the world multiple times. Your work with AIDS, your work in Haiti, your work in Sierra Leone, my goodness. So if you had to distill some of the take-home messages for our global audience, even from your most recent trip as it relates to building a more equitable system, what would you advise our colleagues from around the world?
Well, first of all, thanks so much for letting me be part of this, David, and all of you who organized this. I just got back from Sierra Leone, and I'm still in transit, and I just want to give that as an example of lessons learned, hard lessons. I never set foot in the place until 2014 when it became clear there was a major Ebola epidemic, and one for which that region was uniquely ill-prepared. They didn't have the staff they needed after the war, the Civil War. A lot of people know about the Blood Diamond War. Didn't have the stuff they needed, the supplies, didn't have the space. A lot of hospitals and clinics had been destroyed during the war. They didn't have the systems. And so, too, was the case in Liberia, and to a lesser but important extent in Guinea. So that region, had to learn the hard way about things like social distancing, mask wearing, contact precautions, PPE,
Wow.
and later how to roll out a vaccine. So I think a lot of the lessons that we've learned in some of these settings that seem so different from Italy or the United States are important ones. And when you think about Rwanda and what it's managed, then you can find a lot of very good lessons, not just for Sierra Leone and Liberia, but also for the United States. And I'm sure Chelsea and others will have something to say about those lessons as well.
Great. And we're going to come back to your experience as well, Paul. Thank you so much. Well, Walter, great to see you. Great to be together. My goodness, Italy has been sort of the test bed for the whole world. What you went through a year ago now, how you've recovered. So I guess it's sort of a similar question that I asked Paul. Can you distill for our global audience, what were some of the take-home messages that you and your colleagues learned and through the suffering that Italy just recently went through?
Yeah, we had to take very tough decision in a short time. I cannot forget when we invited all the ministers of health of the neighboring countries in Rome to explain that we were going to lock down the country. So for the first time in the modern history, that an entire country of 60 million people was locked down for 2 months. And this decision that I still remember the face. They couldn't believe it. And they immediately thought that they were going to do the same in their own country. And at that time was unimaginable. But that was a decision that we took to protect the South. Because as you may remember, the epidemic started in the North, which is much richer and much better equipped and was a disaster. We couldn't imagine if the epidemics could strike the south of Italy. And in fact, afterwards, this decision saves approximately 40,000 lives in the south. So that was really, really difficult to take this decision. Unfortunately, I must say that the lessons was not learned because whenever summer came, everybody forgot it. And they tried to reopen it, everything. And the second wave strike and the third wave strike, and now all the country. Now, of course, we have to protect the poorer. In a country like Italy, where we have a national health service, is not a problem of geographical distribution, it's a problem of socioeconomic, and geographical. And we have to manage like this. And I hope that in the future, we take a memory of this lesson.
Wow. Well, I hope we'll be able to draw on that globally, Walter, and we'll come back to you about some of the additional lessons. And I can't help but mention the special relationship between Jefferson Health in Philadelphia and your amazing organization in Rome. You served as an early warning system for our physicians who were in touch with you Christmas time a year ago. And they said, be careful, here's what's coming. We were lucky to have your help, and something I know that my clinical colleagues will always be grateful for. Well, speaking of grateful, amazing to have Chelsea Clinton here. Thank you too for joining us. The work of the Clinton Foundation. So you're probably the best person to address these public-private partnerships. What do you see the role of the foundation and the learnings that you've been able to garner from this dreadful year we've all had?
Well, thank you, David, and thank you to the Vatican for convening us virtually. I want to acknowledge that this still is very much an awful time that so much of the world is living through. And I think it is important that we recognize that we are still very much in this together, albeit while, here in the United States, we continue to vaccinate, on average about 3 million people a day. Our experience at home is diverging rather rapidly from so much of what the world is continuing to endure. And that not only do we have a responsibility, I think, a moral urgency to try to help alleviate suffering around the world, it also very much is in our own economic security and public health self-interest. And so, just your question about public-private partnerships, my father started the Clinton Foundation 20 years ago, really in reaction to another yawning, growing, and indefensible health inequity that HIV positive people here in the United States and Italy and much of the Western wealthier world were able to access life-saving medicines, and so much of the world who weren't in those wealthier geographies were not able to. And so he started the foundation to really change the antiretroviral market from one that was a high price, low volume dynamic to a high volume, low price dynamic. And we proved, as Paul kind of had been saying for many years, even by that point, 2 decades ago, that when people have access to medicines that will save their lives, they will take them. There will be good adherence. People want to live. People want to be able to be there for their children, their grandchildren. People want to be able to work and to thrive. And so I find it quite painful, David, at this moment that kind of there is this posture of, well, if we have TRIPS waivers, which are important to help democratize and unlock access to the mRNA technologies that we know have been so powerful for the COVID-19 vaccines. Like if we do that, vaccine manufacturers won't be able to make them. Or if we do it, how do we know that they'll be able to be distributed? Or if they're distributed, how do we know people are going to line up to take them? Well, we know because we've been to this dance before. And so right now, kind of to your question of public-private partnerships, I think we have an urgent need for the largest public-private partnerships that we would have ever seen across the globe to really rapidly scale up vaccine manufacturing and distribution around the world, because it's just inexcusable that we aren't already doing everything that we know could work to be able to do that.
Well, so heartfelt, Chelsea. And as we're here today, of course, what's going on in India and in Brazil. And of course, this group embraces the fact that we're only going to be safe here when we're safe everywhere. And that is the key message. And we'll come back to you more and talk about misinformation and what's limiting vaccination. I mean, incredible. And we appreciate, of course, at this conference that, 16% of the world's population owns more than half of all the doses. So a very small percentage of the globe's total population is driving all the ownership. And we can talk a lot about reducing hoarding, reducing the limits on the patents. I mean, there are things that definitely can be done. Well, Paul, back to you. So again, in your experience, let's talk about Rwanda. Are there specific references and specific stories that you think we can message better, especially given the current crisis?
Well, first of all, that's exactly, the place that was on my mind as we were speaking. Since we've been summoned by the Vatican, and I have to admit, I get a personal charge out of that, being Catholic. I just want to go to some language that wasn't really used in Rwanda, but is rooted in Catholic theology and Catholic social teachings, and that's the idea of a preferential option for the poor. In other words, I'm not a theologian, but the idea being, God loves everybody and is fully capable of it, but particularly the poor. And pathogens and pathogenic forces, pathogens like COVID, pathogens like Ebola, pathogenic forces like racism, gender inequality, they also make a preferential option for the poor. So why don't we in medicine and public health say, yeah, we're here for everybody, but we're particularly there for them? And what the Rwandans did was not to use that language, which really emerged largely from Catholics in Latin America. And I hope to see it taken up everywhere. Certainly, Francis has embraced it. But what the language they used was right out of development economics. And they said, we're going to focus on the bottom quintile. That means, the poorest fifth. And we're going to focus on the rural over the urban, and the widow and the child and the genocide survivor, And so this language was different and well suited. Chelsea has been there quite a bit as well and worked with the Rwandan authorities, as have I, for many years. But the effect was the same. That is, by focusing on the most vulnerable, all of the rollouts for everything from AIDS treatment, tuberculosis detection and treatment of stunting, a number of initiatives that were rolled out through the public care delivery system, they were targeted on those who would benefit the most, which is the most vulnerable. And I think that's a lesson, that we need right now. I know we'll get into the question of vaccine hesitancy, which is a very complex issue and not a simple one. But, when you're visibly serving certainly as a clinician, you know, when you're visibly serving those in greatest need, they may be the sickest, they may be the poorest, but somehow they're the most vulnerable. That generates trust. And I think that's what you see in Rwanda is a great deal of trust in the public healthcare delivery system.
Wow.
That, you know, we sorely need in the United States. I don't know about Italy, but you know, and in many places in in the world, it would be great to have that kind of trust.
Well, Paul, your experience from Rwanda has direct application to the great city of Philadelphia, right? Where 1/4 of our population lives in poverty, and a city with 5 academic medical centers, we still do not such a great job of reaching out to the communities that need us the most, because our system is focused on healthcare service, not on improving health. And so what a great example you've set, and we could bring those lessons from Rwanda right to Philadelphia. No question about that. Well, Walter, back to you. I know that you've also led through your global work with the Federation of Public Health Associations all over the world, and we were supposed to be together in October in Rome. The use of big data, could you tell us a little bit more about that, especially in the Italian experience as you were tracking the progress of the pandemic? How did you and your colleagues organize the data, share the data, and are there lessons that we could learn from the organizing that big data?
I think that, and the pandemic has confirmed this, having good doctors is, of course, the most important prerequisite. I mean, human resources are really important, but management has become important as well, because the organization of healthcare is so complex, and the pandemic has put in danger millions of, for instance, oncological patients. I mean, only in Italy, we have lost 2 million oncological visits, and 3 million of oncological screening. So this means that we have to catch up. And to catch up, of course, it's very important that you base your decision on data, on solid evidence. And with this, you can help to target the precise part of the population that needs more. With this, you can target the prioritization of resources. With this, you can take the decision that do not harm a substantial part of the population, privileging the one that are needing most, you know. So essentially, but for this, we haven't enough data, and moreover, we haven't enough expertise. You know, now essentially it's very difficult, because when we speak about big data, we speak about millions and millions of data. And this is not very easy to do. And in Europe, it's also particularly difficult because of the attitude of member states to protect, which of course is very important, the privacy of people. So you have to find a new balance. And now in Europe, there is a big discussion on this. So reforming the global, the protection data regulations in order to do that. I think we are just at the beginning of a new journey in which we will regularly use big data for taking our decisions.
Wow. And I hope we'll be able to share that worldwide, right? That would be a great outcome from this. If we could learn and share that data and our experiences in the US with yours, Rwanda, and everywhere, that's obviously very, very important. Well, and also, Walter, I think you brought up an important point. We have clinicians who have coined the term the pan-didn't, meaning the people who didn't get care who needed it. And at Jefferson Health, our 14 hospitals, we're seeing unbelievable backlog in folks who have missed all of their preventive care. And we're really encouraging people to get back to it, because that's actually how you start to improve health. It's incredible. Well, Chelsea, back to you.
And David, I was just going to say, you know, I also don't want to lose the focus on children's well child visits as well. And I don't know kind of what it is in Italy, but, you know, here in the United States, you know, it's just not hyperbole to say that actually tens of millions of well child visits were skipped or lost, kind of whatever the most appropriate framing is, over the last 14 months. And so we also, need to focus on, a class that is especially vulnerable, our kids,
Great
to ensure
point.
that we're catching up kids too, to get their routine inoculations, to get their routine blood lead
Right.
level screenings, and just so much else. So I didn't want to, I'm so
great.
sorry for interrupting, but I didn't want to miss including kids in kind of the really, I think, helpful framing of.
Really great point. And right, all the talk about vaccinations, we can't overlook the critical ones that are also central to getting back to opening school, right? Really, really important. Well, Chelsea, earlier we just touched on the notion of, vaccine misinformation, vaccine lack of confidence, vaccine hesitancy. I mean, what's happening at the Clinton Foundation? How are you helping to focus on the fact that still millions of Americans, millions of educated folks still don't want to get a vaccine, something that is so vexing to a group like this? Can you shed some light on that for us?
Yeah, thank you, David. I mean, we are doing a lot to try to help both ameliorate and respond to hesitancy, as well as to help reach out to people who are kind of currently in vaccine refusal. And I do think it's important to disaggregate those groups. So there's people who are hesitant because they have lots of questions about the speed at which these vaccines were apparently developed, and so they're worried were steps skipped. Questions about kind of what's gone into the vaccines. Do we really have kind of confidence in the integrity of the ingredients? Admittedly, also some kind of conspiracy theories around, are there microchips kind of embedded in the vaccines? Kind of, is this some plan for the government to, or some other authority to kind of track individuals? And so, there are kind of those sorts of questions, which I think, are very much on a spectrum, and yet kind of which have very real answers to them. And then there are the people who are kind of in the refusal group right now, who just don't think it's relevant to them. Often young people who just say, no, like, I'm not interested. If I get COVID, it's not going to be a big deal, which I think highlights another kind of failure of public health communication in this country. Or who think maybe in a couple of years when I just know more, you can't tell me that we really know enough. I'm not persuadable. So I do think, we just have to be, cognizant that there are kind of very different reasons why people may say, not now or not ever. And then, of course, there are kind of people who have been themselves, or kind of are part of communities that have kind of been mistreated, maltreated, kind of by our healthcare system for generations. So, kind of how we address vaccine hesitancy in incarcerated settings has to be different than how we think about that in non kind of incarcerated settings. How we talk to kind of Black Americans, Indigenous Americans, Latinos, who kind of know that members of their communities have often been mistreated or even kind of manipulated and exploited by our healthcare system. So, I think kind of we try at the foundation to really help equip trusted messengers, whether in healthcare settings or not. We've done work with a number of different religious communities, including some of our Catholic partners, to really help ensure that kind of whomever is able to have a conversation really is able to preempt or to answer whatever questions people may have. And even for those who are currently in the refusing kind of group, to kind of message, like, the vaccines are waiting for you, and the vaccinators will be too, whenever kind of you are comfortable, and we are going to keep, reaching out to try to help you get comfortable. So we're just doing everything and anything we can, as I think, so many of us are in this moment. And then we're increasingly thinking about how we can engage in this work globally too, because unfortunately, vaccine hesitancy and vaccine refusal, are not just uniquely American challenges. And then the last thing I'll say, David, is just on a personal level. So kind of just need to be clear, this is me just speaking, as Chelsea, and not kind of with the Clinton Foundation or with the Clinton Health Access Initiative, is that I personally very strongly believe there has to be more intensive and intentional and coordinated global regulation of the content on social media platforms.
Totally.
We know that the most popular video across all of Latin America for the last few weeks, that now has tens of millions of views, is just an anti-vaccine, kind of anti-science screed that YouTube has just refused to take down. We know that often anti-vaccine content that is created in the United States, unfortunately, kind of flourishes across the world, kind of, through the pathways of WhatsApp, Facebook, Instagram, and we know that kind of, because I have tried appealing to kind of the leadership of these companies to do the right thing has just not worked. And so we need regulation.
Well, I'm very glad you brought that up. And I hope that with your influence and the influence of the foundation, you'll continue to fight that. And I heard, I think, two key messages from you, which is different messages for different groups, both domestically and internationally. And to think that one message is going to convince everybody, obviously very naive. And in our great city of Philadelphia, boy, your take homes are still very apt. Okay, well, watching the time, we have time for one more big important question talking about the future. We'll go in the same order. So here's the question. If we had to build the equitable healthcare system of the future in our own great country, what do you think the key attributes of that system, if you had the opportunity to participate directly in building this system of the future? So Paul, then Walter, and we'll end with Chelsea. What would this equitable system of the future look like? Please.
I kind of wish that you had started with the others because they're better at the policy questions. But just in terms of fantasizing, I can say, David, that it would not be a fee-for-service system.
You bet.
It would have a safety net that was unstinting and did not leave people out. It would focus on the burden of disease. Where does that burden lie most heavily? Again, there's a Rwandan way of doing that. There certainly can be an American way of doing that. It would look very critically at gaps. After looking at the burden of disease, it would look at gaps. What is not being addressed? And I think there's some heartening signs from the new U.S. administration that is fueling some of their thinking as well, the burden of disease and the gaps. And then, just because we're in the middle of a pandemic, and I would just point out that even right down to the technical level of how do we vaccinate?
Yep.
Those are very useful ideas. Like, and to be Catholic about it with this lowercase c, meaning universal.
Right.
The same way of thinking: safety nets, burden of disease, go where the gaps are, and above all, what people are looking for when they're ill is not more disease control, but care, but expert mercy. It has to be, this system has to not ignore those who are already critically ill or injured. Because some of the progressive or self-declared progressive groups are saying we have to focus on the social determinants of disease. Yes, of course we do, but we can never leave out the elderly, the frail, the infirm, the injured. And I've seen that happen way too many times in the response to epidemic. It's cannot be control over care. We have to be a caring, just, and universally accessible system.
So put the care in healthcare, that's for sure. Okay, Walter, recognizing the time, the equitable system of the future, what would be your take-home message?
I fully agree with Paul. Must be a universal coverage system, either based on a national health service or a social insurance, but certainly not a fee for service. And on a practical point of view, considering this as a public good, we have to convince politicians to invest in health and healthcare. So not considering healthcare only as a cost, but as an investment. And on a practical point of view, this means investing in prevention, in public health, engaging citizens and making citizens much more responsible about their behavior, because only 4 risk factors are responsible for 80% of the chronic disease. And also reorganizing health services. Whenever you have a universal health coverage, of course, your services must be reorganized on a population health basis. So essentially looking at the needs and demands on the population and meeting these needs and demands, rather than offering services that are inappropriate, expensive, and maybe making money for the providers. That sounds utopia. It's not.
I don't think so.
There is a substantial increase in part of the world where this is happening. And I hope that is going to happen everywhere.
Great.
You know,
Okay, Chelsea, you get the last word.
I know we have vanishing seconds. I want to emphatically agree with everything, Paul and Walter said. I also just think, we all need the humility to recognize that there is no equitable health system. Like there are gross health inequities everywhere. And so I do think, to Paul's good admonition, we need to have enough kind of idiosyncrasy within our systems to really kind of target those inequities, ameliorate them, and try to obliterate them kind of, for the future. I do think, though, so often in the United States, our healthcare debate is just about coverage, understandably, because we don't have universal healthcare coverage. But I think the equating, of kind of universal healthcare just to coverage really misses so much of what Walter kind of started his commentary on, that we can't not focus on the healthcare workforce. And in this country, we desperately need more well-trained kind of doctors, nurses, community healthcare workers, trained birth attendants, midwives, health techs. And we desperately need to invest in building the training capacities and the educational institutions for people to be able to kind of be educated and train within their own communities, to be able to kind of not only provide the health care, but to certainly center the care kind of in that work and in that mission. And so I think that is hugely an important part that we don't spend enough time talking about.
Well, colleagues, I want to say in closing, thanks again for joining us for this fifth meeting. What an incredible group, and building the equitable healthcare system of the future. We all still have an awful lot of work to do. So thanks again, and ciao for now. Thank you, and God bless you all.
David.
Thank you very much.
Thank you very much.
Dr. David Pierce, President of Innovation and Research of Sanford Health, will speak with Dr. Max Gomez, Senior Medical Correspondent, CBS 2 New York, about investing in health and healing around the world.
So, Dr. David Pierce, welcome. I wanted to ask you about Sanford Health is clearly a very large and innovative healthcare delivery and research system, but you're also involved with international care, which I think is very interesting. Tell me a little bit about the Sanford World Clinic initiative that started back, 2007, I believe?
It did, and thank you for the invitation to do this, Max. Yeah, so in 2007, and this was off of the back of the philanthropy of Mr. Denny Sanford, we initiated a children's research program, and to complement that, we recognized that we could learn from other countries how pediatric or primary care was delivered in other nations with respect to not just the healthcare delivery, but also the other maladies that are there. So with combining, when we're invited to be in a community in another part of the world with our research, we felt that we could make a contribution to those communities and also bring something back to our own communities.
So what have you learned from delivering this in those communities that you can bring back?
Yeah, so, a number of things. Originally, we partnered in just pediatrics and soon recognized that a number of institutions around the world reached out to us to work in other areas. So, for example, in Ireland, we introduced precision medicine, working with a very talented physician there who trained here in the United States, and we introduced genetics in cancer diagnostics and treatments. In Germany, we recognized that they were leading the way in regenerative medicine, in orthopedics, using isolated stem cells. So we brought that back to the United States, and they're now leading the nation in FDA approvals. In other countries, maybe more developing countries like Ghana, we learned the complexity of really trying to deliver healthcare in a rural environment, much like our own here in the Dakotas, but with a whole set of different maladies.
So you have a number of these different partnerships and world clinics established around the world?
We have 10 sites around the world currently. 2 of those are actually in the United States, in rural and urban areas, but we're in 9 other countries.
Let me take you back to Ghana for a second. Why Ghana?
It's all about relationships. We only go where we're wanted. We don't go somewhere and say, hey, we want to establish a clinic here. Obviously, the need has to be identified by the community. And then an individual that we just got to know called Kojo, from Ghana, and he lives over there now, really said that, there was a need and a priority for delivering primary care within a number of communities. So, we established one and then several clinics, really, based on the primary care model we have here in the United States, with high throughput and really just good management of seeing patients through the mix. And that was when we had that epiphany. It wasn't just going to be pediatrics. We wanted to do it across the board in any subdiscipline where a community had a need.
And I know that we've talked about this before, using these clinics now, whether you're trying to vaccinate or whatever, as these kinds of points of contact from which you can expand beyond, say, just vaccinations or primary care, not just to the child, but to the rest of the family and to other types of care?
Exactly. I mean, and this has been one of our strengths here at Sanford, here in the Dakotas. If you take care of the child, educates the parents sometimes. And in Ghana, thank you for mentioning that, we have a program where we're going to be introducing, bringing people into the clinic, whereby, we have this partnership with Amani Ohomi from Samaritan's Feet, who has shoes that are embedded with antibiotics, which should be able to reduce foodborne diseases. So in Ghana, albeit a developing country, if you can give a child a pair of shoes to avoid these types of foodborne diseases, but also give them a vaccine at the same time, it's almost like an attribution strategy as well as doing the right thing.
Yeah, once you get them into the tent, you can actually do a whole lot of different things for them.
Absolutely.
That's terrific. Congratulations on it. Please keep expanding that. It is often said that the Lord works in mysterious ways. There are perhaps few people who can attest to that more than Emmanuel Ohomi, or Manny to just about everyone who knows him. How a barefoot boy from West Africa rose to found and head an international nonprofit organization that has provided shoes to almost 8 million children in 110 countries is a highly improbable story. It begins in a poor neighborhood of Lagos. One of 6 children of an alcoholic father and a very wise mother, Manny would pray every day for 001. Even if there's no breakfast or lunch, at least God give me dinner. Then it was a chance encounter with some missionaries who were teaching a group of children to play basketball in a park where Manny would often sell soft drinks to help support the family. Despite never seeing a ball that didn't need kicking, soccer was the national sport, at age 9, Manny somehow won a shooting contest. The prize was a pair of sneakers, something he and kids in his neighborhood could only dream of. Thus began a passion for basketball. As a high school senior, Manny's dream was to play basketball in America. Manny wrote to a number of colleges in the U.S., and against all odds, 5 responded. How to choose? Manny picked the one with the best-looking brochure. A skinny teenager from Nigeria had a basketball scholarship at the University of North Dakota. But raising airfare one way for a family living on $1 a day meant his mother had to sell nearly everything of value she had and borrowing money from relatives. Then it took intervention by a retired Army relative to get Manny a visa from the U.S. Embassy. After a successful college career, where he met his future wife and was crowned homecoming king, there followed several positions with software companies and a degree from seminary. Manny's story then gets even more interesting. When he returned to Nigeria to bury his father, Manny was reminded of the poverty in his country. He remembered the difference a simple pair of sneakers had made in his life years before. That's when Manny realized he was being called to something bigger than the software business. A casual discussion with his boss during a business trip, a random, almost psychic encounter his wife had with a woman at a conference, and a lot of prayer kept pointing towards a vision to put shoes on children around the world. But Manny and Tracy had 4 of their own children, and he also had financial responsibilities for his family in Nigeria. Then Manny gets let go from his job with enough severance to allow him to pursue what God was calling him to do, start Samaritan's Feet, but not without a rocky start. Ill-fated TV interviews somehow led to meeting Maya Angelou, who sensed his passion. This led to a huge national exposure when they convinced a collegiate basketball coach to coach a game barefoot. Then more national television exposure, unplanned meetings with executives of several shoe companies who ended up donating millions of shoes. And finally, another chance connection at a speaking engagement in South Dakota led to a materials scientist who helped Manny develop and manufacture the World Shoe, a size-adjustable shoe made of antimicrobial material that repels parasitic and bacterial infections, the leading cause of amputations in shoeless children. To get to this place has taken luck, God's goodwill, and Manny's fervent belief that to whom much has been given, much is required. His wise mother would always tell him, "Son, I've seen people survive for days without food or without water, but no one survives long without hope." For providing hope to millions of children around the world, we award Emmanuel Manny Ahome the Pontifical Hero Award for Inspiration for impacting children's health worldwide by enabling our children and our children's children to lead happy, healthy, and productive lives. This session features 3 experts discussing how to make drugs and therapies for chronic disease more affordable and more available. Please welcome Dr. Aaron Kowalski, Shelley Lyford, and Dan Lillianquist. They share their views with Dr. Mark McClellan, Director of the Duke Robert J. Margolis Center for Health Policy at Duke University and an independent board member for Cigna and Johnson & Johnson.
How can we move toward more effective access to medicines while still ensuring that companies can fund the cost, time, and uncertainty of bringing innovative new treatments to market? With COVID vaccines and therapies holding the potential to transform the pandemic, and with new treatments in development from conditions ranging from Alzheimer's disease to genetic diseases, with laboratory research and early studies showing promise for many other unmet medical needs, this question is more pressing than ever before. And so today, I'm really pleased to be joined by Dr. Aaron Kowalski of the JDRF International, Dan Lillianquist of Intermountain Healthcare, and also by Shelley Lyford of the Gary and Mary West Foundation to discuss these topics. It's good to be here with you all, and let's get right into it. Dan, I'd like to turn to you first because you have been involved with Civica RX through your work at Intermountain, which is a new kind of pricing and production model for access to needed medications. Can you tell us a bit about that and also some of the implications for addressing the problem of high and rising drug prices and access?
Absolutely, Mark, and great to be with you. So Civica is a company. It's organized as a non-stock, nonprofit corporation with a very simple mission to ensure that essential medications are available and affordable to everyone. And like most health systems around the country, we've found several problems in the drug market, of course, where drugs are high priced, particularly drugs that are past their patented life and are in the public domain, and found really many areas of abuse. And so several years ago, we started to organize the healthcare industry around capitalizing a democratized public utility that would work with health systems, pre-contract with those systems, with the goal to bring new competition back to markets, drug markets where competition had been stifled or where monopolies exist, with the goal of bringing in additional supply and price stability. And we launched the company in 2018. And we thought it would take us 5 years to get 5 drugs on the market. And we're about 2.5 years in and have over 40, and we'll have 60 by the end of this year. But the mission really is to make sure that when formulas that we've paid for as a society are in the public domain, that they're available and affordable to everyone. And we think that's a noble mission, as particularly at Intermountain Healthcare, when our mission is to help people live the healthiest lives possible. You have to have medication to do that in many instances. And so we're delighted with the success so far and feel like that we have a lot more ahead of us and a lot of good that we can do.
Well, I want to come back to that model and focusing on whole populations and getting them the drugs that they need. But let me turn to Shelley. Shelley, you've been working on drug pricing issues, fighting for lower prices for 15 years, including through your work leading at the Gary and Mary West Foundation in collaboration and supporting Civica RX. Can you talk about how that model can be scaled and also some of the other approaches that you're supporting to address better drug affordability while still supporting innovation?
Definitely, Mark, thank you so much. And I am so proud of Civica and the Foundation's investment in Civica RX, and very happy to be a leader in that nonprofit corporation as the vice chair of the board. But Mark, before we go there, let's talk a little bit about healthcare spending in America. Healthcare spending accounts for 18% of America's GDP, making our healthcare system by far the most expensive in the world. In fact, every hour, the United States spends approximately $420 million on healthcare, a number that is increasing by the minute. There are a number of common sense policy reforms that could have a big impact, and I'm just going to briefly talk about the three that the Gary and Mary West Foundation supports. First, greater competition. As we just heard, Civica is shaking up the industry by manufacturing versions of popular generic medications, which of course is helping to lower the price of those drugs, but also it assures that we have constant supply of those drugs. So to have that supply chain is very important. Second, Medicare negotiation. A current West Health study found that 112,000 Medicare beneficiaries die annually because they cannot afford to adhere to their drug therapy. This is outrageous, Mark. In fact, let's just think about this for a second. The largest purchaser of drugs in America is not allowed to negotiate. From the Foundation's perspective, this is simply un-American. We have effectively neutered capitalism. And finally, number three, value-based care. We need to flip the script and pay for value over volume. When it comes to prescription drugs, that means linking pricing to outcomes. Value-based pricing would require that drug manufacturers actually have skin in the game.
Great. Shelley, thanks for that overview. I want to come back to some of the issues that you brought up, but first, let me bring Aaron into this discussion. Aaron, at JDRF International, you all are working to get to lower prices, greater access for insulin for diabetes patients, including you yourself. And as you know, insulin treatment's been around for a really long time, but the co-pays, the out-of-pocket payments that many patients are paying are still really high. And not only that, as you pointed out, there are a lot of innovative forms of insulin that patients could benefit from, some of which have been developed and are not that affordable, other of which are still in the pipeline. So tell us a little bit about what you're doing about this very visible problem of access to affordable treatment for people who really need it.
Yeah, well, thanks to the organizers for having me. And you're hitting on a topic that's obviously kind of a poster child right now for the problems we're facing in America with access to drugs. Insulin is a life-sustaining drug. People with type 1 diabetes die if they don't have access to insulin 100 years ago. So this year actually marks 100 years since the development of insulin and the saving of lives of people with type 1 diabetes. And here we have now the inability for people to afford it, whether they're uninsured or underinsured, or now we're seeing the preponderance of high deductible plans. So JDRF is really trying to fight on all fronts. We've been working with members of Congress, the Diabetes Caucus in the Senate and the House, with payers looking at innovative approaches to provide insulin at reasonable out-of-pocket costs, and really fighting against the rebate system. Just as Shelley pointed, this is this perverse system where we're seeing competitive drugs driving prices up instead of down makes no sense. We need to ensure people have access to insulin. It sustains their lives.
Yeah, and I'd like to pick back up on some of the points that Shelley raised about potential policy directions to address it. Let's start with Medicare price negotiation. That one's certainly been in the news and gotten a lot of attention. As I see it, there's several ways in which that could work, and I'd appreciate views from the panel on this. One is to give the drug plans that are competing now, so there is competition, the drug plans that are participating in Medicare, more ability and maybe more oomph, more pressure to push for lower drug prices. When we started Part D, I was there. We set it up in a way where the government paid for most of the costs for people who had high-priced drugs, thinking that those catastrophic expenditures would be ones that would be hard to get insurance plans to cover. We've never done drug insurance before. Turns out now we've got a lot of competing plans. The premiums in the drug benefit have stayed low, but we're still seeing these high prices for many of these top tier drugs. So there have been some proposals, for example, to lower the amount that the government pays in that range, shift that risk back to, as Shelley was saying, the manufacturers and the drug plans. That could help lower prices. There also have been proposals to give drug plans, or maybe the Medicare program doing it itself, more ability to negotiate lower prices by restricting formularies or limiting drugs that can be covered. Right now, in at least 6 classes of Medicare drugs, including cancer drugs, drugs for degenerative neurologic conditions and others, the drug plans have to cover every single drug for all of their patients, which gets in the way of negotiating authority. Another way to do that would be more like what the VA does, which gets very low prices, on par with Europe, where they only have to cover one drug in a class. They get the benefit of some government so-called best price rebates. It's a different kind of model, but with considerably more restrictive formularies. Another way that's been proposed by House Democrats is to take the prices that we see in other countries, which use models much more like what I've described, and tell the drug manufacturers, essentially, if they don't fall within a range of those prices, they can't sell in the US markets. Now, both of these have been controversial. People want lower drug prices. They don't necessarily want formularies. They don't necessarily want drug manufacturers not to bring drugs to the US market or innovate as quickly. I'd appreciate thoughts from any of you, and not sure who wants to go first, on how we can move forward with a negotiation approach that's stronger, either involving Medicare directly or maybe giving more authority to the Medicare drug plans. Any of you all want to comment?
Great, I'll go ahead.
Yeah.
So, Mark, thank you so much. You just gave a tremendous overview of all of the options. And honestly, Mark, we have to get there. It's not a matter of if, it's a matter of must, because we are talking about life and death. The consequences of high-priced healthcare are universal, and there is tremendous pressure, as you just stated, in Washington, D.C., to act, and this is a good thing. In fact, Mark, from my perspective, I believe COVID-19 has shined a light on our broken system and only made addressing the issue of high-cost drugs and healthcare even more urgent. Before I get into answering your question absolutely directly, I just want to note 2 quick things that we learned from our Gallup polls. Even in a pandemic, we found that people are avoiding care because of the potential cost. Just last month, our Gallup poll found that 46 million Americans avoided needed care over the course of the pandemic due to cost. And even more startling, this Gallup work also found that 9 in 10 Americans are fearful that the pharmaceutical industry will use COVID to raise prices. So, to your question, Mark, the Gary and Mary West Foundation is confident that action is on the horizon, particularly to address prescription drug prices in the very near term. For example, House Democratic leaders are intent on including a measure that would allow the Secretary of Health and Human Services to negotiate lower prices for prescription drugs as part of that incoming infrastructure package. Secondly, I believe there are roughly 24 bills that are floating around Congress right now that would actually alter how drugs get marketing exclusivity. It would also require companies to report planned price hikes and also allow the government to directly negotiate prices. And further, there are about 6 bills in the House and Senate right now that would actually remove the restrictions for the federal government to negotiate drug prices directly for Medicare consumers. So as you pointed out, Mark, the time is now. There are options on the floors, and we need to get to work.
Dan, any thoughts to add to this?
Yeah, look, I'd love to jump in, Mark. So I served a term in the Utah State Senate and was involved in our budgeting. And the reason I bring that up is I know of no other area anywhere in government where we've allowed an industry to have a backdoor into the federal treasury. Hospitals don't get to set Medicare rates. But with respect to drugs, there's almost this feeling like, we get to set it wherever we want and you have to buy it. And the challenge there is that means that there's unending money for lobbying and access to politicians, et cetera, because, it's just stunning to me. I'm not that optimistic when the easiest money to raise in Washington comes from big pharma, that this is likely to happen through congressional means, but it should happen. We negotiate for everything else except for this. So one of the things we're excited about what we're trying to do with Civica, understanding that we won't be able to solve everything, but with an industry-wide movement from people who actually end up paying the final bill, in this case, health systems, but also payers, we think there's a real opportunity to start addressing some of these failures, because it's not just the patient to pay, it's the payer that pays. It's the health system that pays. And what we've been encouraged by is the movement we've had without needing actual congressional approval to begin setting fair prices in a market through a democratized public utility model. And but it's going to take a combination. We think we've got a model that can address drugs that are clearly in the public domain after their patented life. And that's where Civica is focused. But look, it is absolutely asinine. And to think that the federal government and that the taxpayer should expect a whole industry to have a backdoor into the federal treasury, it's just not right. So, hopefully we'll get there, and we're going to do certain things we can, again, in the off-patent space to fix things, but it won't fix everything.
And just to follow up on that point, as I understand what you're doing in the off-patent space is setting up these longer-term, larger relationships with a manufacturer of the off-patent drugs with an eye towards how can we get enough drug to be available over time to serve the population that we're treating, and how can we get competition at that level, not just try to do it on a fee-for-service patient level basis day to day, really plan out a population level model. Is that right?
Yeah, that's correct. I mean, Civica is really simple. When a drug market is failing, where there's price abuse or shortages, what we do is we organize the demand side of the equation, make long-term purchase commitments through a not-for-profit structure, and enter those markets to stabilize that market, setting what we think is a fair and sustainable price. And what we've been able to do with 41 drugs so far is actually stabilize and bring a fair price to the market. We don't have to make every drug, but Civica will enter markets where there's abuse and help make sure that patients aren't being exploited by market failures. But that only works so far. I mean, with the patented space, Mark, the federal government has to be able to negotiate prices and represent society as a whole in making sure they're getting appropriate value for the tax dollars we spend.
Yeah, and I want to come back to this model of trying to work for patients, the population level, to supply needed drugs at an affordable price. In the meantime, there is some government price negotiation in some other areas. I mentioned VA earlier, where unlike Medicare, there are much tighter formularies. So the certain drugs can be excluded. There are additional rebates that if some other payer gets a good price, that automatically goes over to the VA. Those are the kinds of steps that you want to see in Medicare, because there has been some pushback when, for example, the last administration tried to give drug plans more ability to negotiate by saying, well, you don't have to cover every drug. If there's several similar brand drugs available, say for treating a certain kind of immune condition or cancer, you don't have to cover all of them. But that was pretty strongly, pretty strong opposition to that in Congress and was repealed by the new administration. So you say a little bit more about how you think that price negotiation could be made more strong, and any concerns about access to medicines as a result.
Well, look, and you know this, there's a lot of Me Too drugs out there. And there's really, the FDA doesn't do any head-to-head comparisons. They just do it based off of placebo. And when you really think about value, what a taxpayer should be hoping for is value for the dollar we spend. The federal government, the FDA is even prohibited from even asking those questions. That's a place to start. One of the things we've loved from the very beginning with Civica is our partnership with the VA and with DOD, who've been working with us, because even though you have negotiating scale with the VA and DOD, oftentimes if you're dealing with one manufacturer on the other side of the equation, you're a price taker like anybody else. So this is, look, a multivariate problem, but I think going back to what Aaron said, we've got to break out of the opaqueness of the model, the rebate structures that really damage, frankly, the people who get damaged the most by the opaqueness of the model and the backdoor rebates are the cash pay patients who have to pay the highest price to get medications they can least afford. And so, I think awareness and visibility is important. Having models like Civic is important, but the broader debate has to come by the society in general to say, look, enough. This is killing people every day in this country. And I think it's frankly going to be forums like this will help drive that conversation forward.
And Aaron,
I'm sorry, Mark, I totally agree with what you said, Dan. And in fact, I think it's almost impossible to try to even follow the money. When you follow the dollar and how it flows through from the purchaser of the drug to the manufacturer, it's almost impossible. We need greater transparency.
And Aaron, we've seen some proposals to try to get to that transparency. In fact, the last administration had one about rebate pass-through, which was intended to be more transparency. Now, that proposal by itself was evaluated by the actuarial experts in Congress as saying it would actually add to prices, so might provide more pass-through and more transparency, but not necessarily lower prices. What do you think? You're dealing with both drugs that have been around for a while, some of the so-called older insulins, as well as a push towards innovation with better, longer-acting, more effective insulins for certain patients. So you've got both the innovation side and the affordability and transparency side right in front of you for your patients. You have some additional thoughts about how better, more effective steps on negotiation might work?
I think a couple of thoughts. One is what model works here. JDRF has never said that companies shouldn't make profit. Companies need to profit. There needs to be continuing innovation. My brother and I come from a time where we used to use cow and pig insulin, and it was a dark ages of diabetes. Today's insulins are much improved. There's still room for further improvement. However, as Dan pointed out, people can't fundamentally, particularly cash paying patients, can't pay out of pocket. I have a number of families who tell me it is cheaper for them to fly to Canada than it is to buy their insulin that it is to buy in the United States under their plans. So we've been arguing from a variety of different perspectives on the insurance. For folks who are insured, we've been strongly arguing to payers that insulin should be off the deductible. We can demonstrate very convincingly that it is cost saving, obviously to the people with diabetes, but when people don't take insulin, they often end up in the hospital in DKA, which is much more costly to the payer. So looking at models that are driving prices down, I think we can have profitable insulin in the United States, but it needs to be a competitive market. We need to look at the role of deductibles in life-sustaining drugs like insulin, because ultimately, as people become more reliant on high deductible plans, this is going to impact more and more people.
Yeah, and there have been some proposals around those high deductible plans to have a carve out for really effective essential medications. I mean, there are two reasons to use a copay. One is to deter use that might be of low value, and there's certainly a lot of low value care out there, as Shelley pointed out. But the other is just to shift costs and keep a premium down. This seems like more in that category. So with that in mind, I want to go back to Dan and bring you all up to discussing what we've seen happen in the pandemic, where by definition, we had no effective treatments or vaccines at the beginning. And we've seen incredible progress in making better vaccines and towards making better therapies available And it hasn't happened under the business as usual traditional model. Number one, and we do a lot of work in this area at our center where we focus on more value-based approaches to drug purchasing and healthcare more generally. But number one, the federal government working with the private sector developed a clear path for what would be required for bringing a new vaccine or a new therapy to market. Number two, there was collaboration between the manufacturers, again, supported by governments in the US and around the world, to set up clinical trial networks that were feasible to implement in a pandemic so that we could enroll 30, 50,000 patients of very diverse backgrounds in large scale vaccine trials to get to definitive answers about safety and effectiveness quickly. And number three, different kinds of purchasing arrangements, Dan, one that are much more like what you described. So instead of having the manufacturer try to develop the product on their own and hope for the best with fee-for-service pricing at the end, instead there were large advanced contracts made to cover populations over a long time period, which potentially meant sufficient revenues or more than sufficient revenues for the manufacturer, but also made a much larger supply of vaccines, of some of the new therapies like monoclonal antibodies available at a more affordable price, really with no copays in most ways that these vaccines and drugs have been implemented. So it sounds much more like your model for drug development and drug pricing just applied to the pandemic. And I'm wondering if, Dan, if I could start with you, do you see some lasting changes that could potentially have implications beyond the generic drugs you're looking at for how we can support better innovation, bring public-private collaboration to bring costs of development down, different kinds of pricing models that are based on making drugs available at the population level to patients who need them, other steps in that direction?
Oh, absolutely. And Mark, one of the risks when you talk about drug pricing, et cetera, in the market is to think it's all bad. What we've seen during COVID-19 has absolutely been astoundingly good. The fact that we're vaccinating people with vaccines that were developed so quickly and effectively, it truly is astounding. And it is the very best of what the pharmaceutical industry can do. And I agree with Aaron. I'm so glad today that my two type 1 diabetic brothers, and my dad's an endocrinologist, as is my brother, that they're dealing with insulins that are really effective. And we want that to continue. And I'm thrilled with the actual innovation. What I find so fascinating about the COVID-19, this new model, is that if you can give a predictable return to a manufacturer, they get out of the game of, oftentimes we have a new drug, people will price it because it's like a game of hungry hippos. You just have a limited amount of time to get as many marbles back as you can. And so that's why you see a lot of really high pricing because they expect a Me Too drug to come in, et cetera. But if you can spread out the return expectation over a reasonable period of time and say, look, we want you to make a good return. We want you to get an innovator's return, and we're willing to price this out over a period of time. That's a very, very attractive model. What we found at Civica, we've not decided to do this yet, and we may someday, is that we have new innovators coming to us to say, look, we do have this innovation, but we would love to commercialize it in a socially responsible way that allows us to spread payments over time, but come to a market price that's actually achievable for regular folks, rather than feeling like they've got to price it extremely high, generate their returns within a year or two because they know somebody's going to follow on. It's just changing the dynamic. And I don't know exactly where it'll go, Mark, but the ingenuity and the partnership really feels like a pivotal moment. And so we've watched it with great interest and sincerely hopeful that we can move faster and create models that just keeps the innovation coming, gives more predictable returns that are societally affordable. We'll see where it goes, but I'm encouraged with what we see.
Much higher volume of patients to spread that cost across if you're pricing at the population level here. And since most of these drugs and innovative products, so much of the cost is up front, there is additional cost of producing the products, but much lower than recovering all that investment, as you described. Aaron, you're working on some innovative models too. Anything you'd like to add at this point, based on what you see that's promising for breaking us out of this logjam?
Yeah, well, I refer to some of the ways that I think payers can cover insulin and reducing rebates. I think there are broader questions of diabetes being a chronic disease, on how we treat diabetes. And ultimately, we see some incredible models being employed in Europe that are driving per patient per year fees for payers, allowing clinicians to distribute time more effectively and drugs and devices more effectively. And the outcomes are stunningly better. And they can be measured against the current state of care. So, these are bigger leaps, but I think hold tremendous promise to deliver better overall diabetes care at lower cost.
Yeah, and I would say that, and Shelley, I'm going to come to you as we wrap up this session, as I know how passionate you are about these issues too. But that idea of moving to sort of a per person per month or per person per year is something that also is holding some promise in helping us get to better health care. So many of the healthcare providers in the United States that were hardest hit in the pandemic were ones that were similarly being paid on a fee-for-service basis rather than being paid to deliver what patients need and be able to invest in data systems and telehealth and home-based support, team-based care, which goes right along with the new kind of model for drug pricing like you were describing in some of those innovative European models. And I bet Dan and Intermountain would be happy to work with you on that too. But Shelley, we've only got a minute left. I know how passionate you are about this. How can we all work together to get something constructive done here?
Well, Mark, first of all, I'd like to say that at the Gary and Mary West Foundation, we are good capitalists. And it's not mutually exclusive to lower drug prices and also have continuous innovation. As you have outlined, it is absolutely incredible that we have got numerous vaccination options and that we've got those in less than a year. I'm so grateful for the pharmaceutical innovation that exists. However, our research found that the pharmaceutical industry could sustain a $1 trillion loss in revenue over 10 years and still be the most profitable industry in the country, all while maintaining the same level of innovation and R&D. So to suggest that the pharmaceutical industry cannot sustain any loss or that they would go out of business, that's a complete farce. They can and they should lower the cost of drugs. There are so many options. We covered them today through the Civica model, through the European models, through just a more holistic approach. There is absolutely no excuse to not lower the cost of prescription drugs. Everyone is going to need a prescription drug at some point in their life, and they should have access. They shouldn't have to choose between paying their mortgage or paying for a life-sustaining drug.
Well, Dan, Aaron, Shelley, I want to thank you all for a heartfelt discussion on a very challenging issue. I hope, in fact, we can make some progress. COVID has shown us that we can't keep doing business as usual, has shown us some new business models, has shown us some new ways to move forward, and really appreciate the opportunity to discuss these very timely and critical issues with all of you.
Thanks for having us.
Thanks, Mark. Good to see you guys.
Thanks, everyone.